When to consider genetic testing for inherited cancer syndromes. Developing a keen eye for patterns suggestive of an inherited cancer syndrome is a fundamental skill in modern clinical practice. While most cancers are sporadic, a significant minority are driven by germline genetic mutations passed down through families. Identifying these individuals is crucial as it opens doors to personalized risk management, early detection strategies, and targeted prevention, potentially altering the natural history of the disease for both the patient and their at-risk relatives. The first step in recognizing an inherited predisposition is to be vigilant for specific red flags in a patient's personal and family cancer history. These indicators often deviate from typical sporadic cancer presentations and include the following parameters: early age of onset, cancer diagnosed at an unusually young age, for example, colorectal cancer before age 50, breast cancer before age 45, or any cancer in childhood or adolescence are strong red flags. Multiple primary cancer, the same individual developing two or more distinct primary cancers. For example, a woman with both breast and ovarian cancer, or a man with prostate and pancreatic cancer, bilateral or multifocal disease, cancer occurring in both paired organs. For example, bilateral breast cancer, bilateral renal cell carcinoma, or multiple independent tumors within the same organ. Specific or rare tumor types. Certain cancers are highly indicative of an underlying syndrome, such as medullary thyroid carcinoma, suggestive of MEN2 syndrome, adrenocortical carcinoma, suggestive of Li-Fraumeni syndrome, male breast cancer, suggestive of BRCA1 or BRCA2 mutations, strong family history of cancer, a clustering of similar or related cancers. For example, multiple relatives with breast and ovarian cancer or colorectal and endometrial cancer across multiple generations, especially on the same side of the family. This includes not just first-degree relatives, but also second- and third-degree relatives. Once these red flags are identified, the next step involves consulting established guidelines and testing criteria. Organizations like the National Comprehensive Cancer Network, or NCCN, publish comprehensive, regularly updated guidelines that provide specific criteria for germline genetic testing based on personal and family cancer histories. These guidelines are invaluable resources for clinicians, outlining which patients should be considered for genetic evaluation and what genes are typically relevant. Adhering to these criteria ensures appropriate testing, optimizes resource utilization, and helps avoid unnecessary or uninformative tests. Central to this process is obtaining a detailed and accurate family history. This should ideally encompass at least 3 generations on both the maternal and paternal sides, documenting cancer types, ages at diagnosis, and relationships among affected individuals. This comprehensive pedigree can reveal patterns of inheritance. For example, autosomal dominant clustering, identify specific cancer syndromes, and highlight individuals who might benefit from cascade testing. A seemingly negative family history might still warrant consideration for testing if a patient has strong personal red flags, as de novo mutations can occur. In essence, a proactive approach to identifying inherited cancer predisposition, guided by clinical red flags, NCCN guidelines, thorough family history taking, and expert genetic counseling, is indispensable for delivering truly personalized and preventive cancer care. Now that you understand the clinical indicators and process for identifying inherited cancer syndromes, you're ready to explore genetic counseling in cancer care. In our next lesson, we'll build upon this foundation and explore the next dimension of genomic medicine.